Good evening, everybody. At the outset, I'd like to thank the AIOS for giving me this opportunity to be a part of this webinar. And in the next few minutes, I'll be giving mainly a solo practitioner's perspective of using this ultra-wide imaging system in day-to-day practice. The three eminent speakers before me have clearly given you the idea about use of ultra-wide field imaging in day-to-day practice. However, when it comes to a solo practice, things are a little different. So let's go into it in the next few minutes. Before I go into my points, let me make one thing very clear, especially for my junior colleagues, that dilated stereoscopic fundus evaluation with a binocular indirect ophthalmoscope for peripheral retina and with a 78D or a 90D lens for the central retina is the gold standard still. You'll have these wide field imaging systems helping you, but for a gold standard, you have to do a proper fundus evaluation with indirect or a 90D lens. And also, I do not have any financial interest in the product which I'm going to talk about. That is the Optos from Daytona from Optos. Now, in solo practice, when you are thinking of going in for a higher end technology, it comes with a higher price also. And the financial burden the thing puts on you has to be compared with the clinical benefits and the overall benefit you get from the practice. Now, in our case, why did we go for this system? First of all, when you do comprehensive eye examination in a solo practice, it's time consuming. You start with the optometrist examination, then you send the patient to dilatation. Sometimes the patient has narrow angles, allergies, or infections, and all the situations, you have to spend a lot of time in having a complete examination. And in that starts affecting your practice, because then it becomes a norm that if you go to Dr. Prabhudesai, you have to spend many hours. So to cut down on that, we are thinking of getting an instrument which would help in reducing the time of dilatation and still not compromising on the quality. So last year we had this demo of Daytona from Optos. And in the very first patient, which is a 55-year-old female, with an undilated pupil, in a few seconds, we could get almost a 200-degree picture of the retina. And there was almost an instant display on the monitor screen, and we could even get red-free and choroidal images immediately. So this is how the normal retina looked. This is the red-free. This is a choroidal image. All this we could get in a few seconds. This is my own autofluorescence image taken immediately. And even if we sort of zoomed it up, there was no loss of resolution. So these features really made us think that we should go for this technology. And other benefits, if the patient had these such good images without dilatation, was definitely that we didn't have to wait for sort of checking at the angles, whether the patient had any allergy to dilating drops. We could straightway take the patient, do his primary workup, and get his retina image with the system. So this would save a lot of time of ours as well as the patient. Hence, this technology is there with us for the last 1 year. Now, once we started using the technology, we would find that along with getting these images in the single snap, we could also take images of the far periphery using various gazes. And this also took a few seconds only, the up gaze, the down gaze, the left gaze, the right gaze, and then machine would montage it. And you could still get almost up to 90 to 95% of the retina. And this is what a comparative picture would look like. So almost going to the far peri was possible with this technology. This is an image of a high myope. You could see that because of myopic eye, there are no lashes artifacts coming in, and you could see almost aura to aura in this patient. Also, when we started using this, there are other advantages which were helpful in day-to-day practice, like the machine has an auto capture mode and no moving parts. So you don't have to keep moving the joystick, getting the patient to focus. And within a few seconds, you get a good picture without any discomfort to the patient. And because of this, the staff also can be trained in a very short period to acquire good images. So once the image is taken, the software is quite friendly, and you can transfer the images to the consultant's room with the Wi-Fi, and immediately the patient can be taken up for further consultation. So with this machine or with this technology, you could give comprehensive eye care in a short while without any compromise on the quality. Also, there were other benefits, like if the patient was intolerant to light, young children who just don't look at the light if you want to examine them. And there are certain situations like in case the patient has contraindication to perform fluorescent angiography, like pregnancy, renal failure, or past allergies, we could still take good red-free images, and that would delineate the new vessels or other vascular anomalies, and we could go ahead and do the laser treatment if required. Now, let us see some examples. This is a 50-year-old female who came for a regular eye evaluation for a little blurred vision. On examination, she was noted to have narrow angles, so it was not possible to dilate her. So routinely what we would have done is we do a YAC PI for her, then wait for a few days to weeks, and then call her back, check that the PI is patent, then dilate her, and then do a retinal evaluation. But here, in spite of her eyes having a narrow angles, we could get a very good clear picture of her retina, and you could see that she has diabetic retinopathy, non-proliferative type, with exudates at the macula. So in one examination itself, we could give a comprehensive review of her problems right in the retina as well as in the anterior segment. Similarly, because of the multimodal imaging available because of two lasers being used, the green laser of 532 nanometers and the red laser of 632 nanometers, we can get color, red-free, and choroidal imaging almost simultaneously, and we can add one more screen and get an autofluorescence imaging also. So red-free images help us to delineate the neovascular tissues, microisms, cellophane maculopathies, macular in the day-to-day practice. There may be many more also. Let's see some examples. This is a new vessel which we have seen the nasals to the disc, and this itself is good enough. We can avoid doing FFA in these patients if we get such good images, so that we can save them from having problems. Or this is a case of PDR where you could see all signs, the NVD, the NVE, venous loops, IRMAs, all well seen just with the red-free imaging. Or these are the new ERMs which one can see very well, and cellophane maculopathy with a macular hole. All these are very well seen with very high resolution, and it helps in explaining to the patient immediately what problem he has with his retina. Choroidal imaging is one thing which we hardly use in our day-to-day practice, because red-free we could still use with a slit lamp with a green filter, but choroidal images were rarely seen. And as we started using them, we saw that in many situations they can be very helpful, like to denote the choroidal detachment, to see earlier laser burns, to highlight choroidal sclerosis. So this is a case of post-TRAB where the patient had hypotony, and we could delineate the choroidals well. And on serial examinations, we could see how the choroidals were regressing. Or we could see in cases where laser has been done previously and the patient comes back to you, you would hardly see any laser marks. But if you go to the choroidal imaging system, you could see these laser marks precisely. So we could decide whether any additional treatment is required, and in case required, where to give them. Or this case of panretinal photocoagulation, where we could see the skip areas very well with the help of choroidal imaging. So in case we want to do a fill-in laser, we know where to do it. Or recently, just about 2 days back, I've seen this lady who came for cataract evaluation. Someone had advised her cataract. But when we saw the color image, we suspected that there is choroidal sclerosis. And when we went to the choroidal imaging, this choroidal sclerosis was well highlighted at the posterior pole, indicating that her poor vision was mainly due to this and not due to the cataracts for which she was advised surgery. Autofluorescent images also in a day-to-day practice help in diagnosing and following up diseases or even the regression. Now, this is the case of chronic CSR, where you could clearly see the gutter-like change with central hypoautofluorescence surrounded by hyperautofluorescence. Or a case of medusa, where in the right, you can see that there is a early stage where there is hyperautofluorescence, and with just observation without any treatment, we could see that the lesions are getting regressed and early hypo is coming in. Similarly, in a case of sympathetic ophthalmia, this is a young one-eyed patient who developed sympathetic ophthalmia in his good eye. And you can see the initial phase, there were a lot of hyperautofluorescence lesions, which post steroids and immunosuppressive therapy with the help of rheumatologist started reducing. But when the steroids came down to a certain level, he came back with further blurring of vision. And you can see from this stage, now he has some new hyperautofluorescent areas. So all this can be done in the clinic within a few seconds. So every time doing FFA can be avoided, and still you can treat the patient well. Again, a case of RP rip following anti-VEGF injections. It's very well shown. The bare choroid is very well shown by autofluorescent area with a rolled RP seen as a hyperautofluorescent. And on follow-up, you could see that the bare area is getting increased and the rolled RP is getting reduced. Also, we have seen that in post-operative patients, when the patient comes for a follow-up, it is very easy to image them and avoid discomfort to them by dilating their eyes and seeing with bright light of the indirect ophthalmoscope. Here is a patient who had a partial RD with a large break in the periphery, underwent the routine scleral buckle surgery, and this is the first day post-op picture. With undilated pupils, you could take a very good clear picture where you could see that the breaks are well covered with the buckle. And this is a 1 month post picture where we could see that things are quite good. The retina is well attached, and there is a good buccal height also. So it helps in serial follow-up of the patients without dilatation. These patients who are already having swelling, redness, watering, if you do their quick evaluation, they are always happy. We have also seen that for counseling, this system helps a lot because we could display vivid images in front of the patient. We can compare both the eyes and show them how surgery has changed their situation. Or sometimes even if the surgery, if the vision takes time to recover, we can show them that structurally they are getting better. Now, in this case, just about 2 days back, this patient came, a young 45-year-old male with blurring of vision in his left eye. And you can see here he has dense vitreous hemorrhage. Now, even with a poor vision, we could get this image quite well. So it helps in explaining to the patient that his left eye vision is poor because of this vitreous hemorrhage. Whereas in the right eye also, he would go the same way because there's early pre-retinal hemorrhage here, some new vessels coming up. So this eye, the right eye, needs urgent treatment after doing an fluorescein angiography. So all these things can be explained very well to the patient and his attendant. And this is another patient who had traction retinal detachment, a young female diabetic, causing traction on the fovea, which we relieved by surgery. And now this is the picture post-surgery. And you can see that retina is flat. There is silicone oil in the eye, but we have assured the patient that she will gradually have improvement in her vision. I call it reverse telemedicine. Like if you are outside the clinic and the patient comes as an emergency, the clinic staff can capture the images and send it to you on simple WhatsApp, and you can see the image and advise the patient that if he can wait or he has to go and see someone else. So all these things can be done. So it really helps in helping the patients who report to you even if you are not there in the clinic. And also it's a good way of documentation because you have serial records of retinal images. You don't have to do a paper drawing every time in details. And it obviously has medical legal benefits because you can show that how the patient was before and now what is his situation. So you can get almost up to, these are 4 images shown of the same patient, but you can go almost up to 16 images at one go, and you can always compare between various images. As Dr. Subhadra has already said, we have been very happy with the pediatric patients because we tell them that it's a game. They have to look at this target and they easily cooperate, and we get such good pictures of their retina. And we are very happy with the software because it has a lot of user-friendly things. You can display images side by side. You can go between the modalities and make changes. You can zoom, pan, annotate, and do all those things. So like if an image is like this, you can make it brighter. You can zoom it up. You can see the macula details. You can compare, as the doctor has said already, you can show that there is a cataract in the right eye, the PSC cataract here. Left eye is quite clear, so he needs surgery in this eye if he has visual problems. Or pre-op, we noted this area of TRD, and post-op, we can show the patient that now all this has gone and his vision would gradually improve. Or this is a peripheral retinal break. It's easy to explain them why they need a treatment, even because in spite of his retina being good in the center and vision being normal, is a large break there which needs treatment. And this is, we show him that post-treatment that your treatment has been done well and you would be now safe. Or this is a patient who had undergone a PRP with us, but still his new vessels were persisting. So we did an anti-VEGF injection for her, and post-injection 2 weeks, you can see that the vessels are already regressing. So we can show this, and it is also good for our own documentation and our own learning that how anti-VEGF would be helping in these situations. Also, by routine screening, we see RNFL defects. So not only from the retina point of view, even the glaucoma screen can be done by routinely checking these patients on this imaging system. We can note the optic disc changes. We can compare the 2 discs, the cupping. We can also see the lamina cribrosa quite well with the red-free imaging. And we can denote the optic disc anomalies, like this is an optic pit with fluid here, or the AIONs. And it's also a good way of detecting optic nerve drusen with the autofluorescence. In COVID times, it's as really helped us because we can now have less interaction between the staff. We allot a single staff to the patient and he takes care of the patient. He does a very small primary workup because previously on phone, we have taken all the history. So he just takes the vision quickly, then takes the patient for the imaging. And after looking at the image, the surgeon can decide whether he needs dilatation or he can be sent off with giving the treatment. Social distancing can also be maintained. Machine sanitization can be easily done by using a cling film. I'll show you some pictures. And additional protection to the staff can be done by using non-touch gowns. So this is, we have spread a cling film across this area where the patient's face comes into contact with the machine. As you can see here, there's a cling film. So the patient, even if it touches the machine, there is no problem. And we have made these special gowns. So the patient doesn't touch the machine anywhere. He touches through the gown itself. So we don't have to sanitize the machine, the whole machine after each and every case. And this is a picture taken through the cling film. You can get fairly adequate quality pictures to the cling film also. So in conclusion, I feel this Optos Daytona is a perfect assistant to a Brady practitioner, an assistant who doesn't tire off. He can go on working for hours together, extremely fast, and really works through a small pupil. Obviously, it reduces your paperwork, less retinal drawing, and easily accessible anywhere through Wi-Fi. Easy access data for research purposes. So in conclusion, I would say it's definitely a good buy. And for the company, if they further reduce the cost, there will be definitely more buyers. Thank you for your patient hearing.